Hello and a very warm welcome to this topic-based education session for patients and professionals. This evening's topic is smell and taste changes following a traumatic brain injury. I'm Mags Robinson, Support and Information Officer for Fifth Sense, the charity for people affected by smell and taste disorders. With me today are my colleagues Sally Connick, Community Development Officer, and Sarah Pearce, our Director of Services and Operations. Sally and Sarah will be in the background, making sure everything runs smoothly this evening. There's no news in the background. That's fine. Okay, it's my pleasure to welcome our guest speakers, Dr. Lucia Lee, Miss Lisha McClelland, and Ed Shardlow. Miss McClelland is a consultant ENT surgeon at the University Hospitals Birmingham. Lisha has a special interest in rhinology, and she specialises in smell and taste disorders. She runs the Smell and Taste Clinic at Birmingham Imperial Medical Centre. Dr. Lee is a neurologist at Imperial College London and St Mary's Hospital in Paddington. Lucia is a clinical lecturer in neurology with the National Institute for Health and Care Research. Her special interest is traumatic brain injury, and her academic work is strongly influenced by her clinical practice at St Mary's. Fifth Sense volunteer Ed is our expert patient this evening. In 2005, at the age of 27, he sustained a head injury which resulted in his loss of sense of smell and taste. After almost 2 decades of living with smell and taste changes, I think you'll agree he's a good expert patient for us this evening. So thank you all for joining us. There's just a little housekeeping before we dive into our topic for this evening. We will be focusing on traumatic brain injury, and we may use the term TBI for short. So just to clarify, a TBI is an injury that's caused by an external force, such as, for example, an assault, a road traffic accident, a fall, or a blow to the head. We will not be discussing non-traumatic brain injuries this evening, so the things caused by problems inside the brain, like a stroke. We plan to have a similar event on smell and taste changes following a stroke in 2005 as part of our series for patients and professionals. And this event is being recorded, so please make sure you are muted throughout and be aware that you may be visible on screen. So if you don't want to be visible, then you can turn your camera off if you're not a speaker. If you have any technical difficulties, please private message Sally or Sarah from Fifth Sense in the chat. They'll be dropping links into the chat as we go, and they'll be happy to help. The session will be split into 3 parts. So first, we're going to hear from our expert patient, Ed. Then we'll hear from our first expert patient, Lucia, who'll explain about TBI, how the brain is affected, and the smell and taste changes and other consequences of a traumatic brain injury for patients. Then I'll hand over to Lisha, who will talk about how patients who present to the Smell and Taste Clinic are diagnosed and managed, including some self-help ideas. Please feel free to drop comments into the chat during the presentations. You can also drop questions for Lisha and Lucia into the chat. I'll ask them of your behalf after their presentations, after they've both finished speaking. And please note, our expert speakers cannot give individual medical advice. It would be very helpful if you would prefix your questions with a Q, just so we can spot them easily in the chat. And after the Q&A session, we'll give you some time to complete a short survey, just so we can understand what we did well and what we can do better. Okay, so I'd like to move over firstly and ask Ed to unmute and hand over to Ed. So Ed, could I ask you to start by telling us about your accident and the resulting smell and taste changes that you experienced? Thank you.
Thanks, Mags. So it was almost 20 years ago. I was out after work with friends and had a few drinks. Was trying to find my way home and trying to get a taxi in London just a couple of weeks before Christmas on a Friday night, which was notoriously difficult. And I thought that I'd sort of struck lucky because there was one that pulled up with its light on, but then he said that he wouldn't take me. I have no recollection of the evening and the incident. I don't know if it was my fault or it was his fault, but the facts are that he drove forward, clipped me, and I fell and hit my head on the road. A passerby called the police, and they were very quickly on the scene, and they called an ambulance, and I was taken to hospital, but I wasn't given much sympathy. My concussion was showing very much the same symptoms that you would get from alcohol, from drunkenness, and so that was definitely the diagnosis that the paramedics seemed to make. I didn't get scanned or tested in any way at hospital. I was basically just left to my own devices and then told that I could leave, which I did. And then 24 hours later, I was at home, and I started being sick. And one of my flatmates knew that was a very bad sign and got me back to a hospital, where they did do a scan, and they found that I had a blood clot the size of a ping pong ball in the back of my skull. So I was immediately rushed into surgery, operated on. If I hadn't been, it could have been a lot worse, which I think is an experience that is shared by many, traumatic brain injury anosmics. But yeah, fortunately, it was treated. At this point, I was not aware that I'd lost my sense of smell. I've lost my sense of smell at the point of the impact, but because you don't, sort of constantly pay attention to your smell experiences, I had no idea, and it was only subsequently in the days following that I sort of realised that I wasn't smelling anything. In fact, I sort of had a background smell, which at first I thought was the smell of the hospital, but then it was still there when I left the hospital. And then, sort of discovered that I couldn't smell anything else. So it was, the whole experience was very traumatic. It was, life-threatening, and, made me really kind of take stock of my life and, think about what was important and what I valued in it. And it could have been a lot worse, but I did lose my sense of smell, and hadn't, until you've lost it, you don't know what you've got until it's gone.
Thank you, Ed. Thank you. There's one comment in the chat that says that's exactly my own story 39 years ago. Taxi, pavement, no smell. So it's quite common, and our CEO,
we should form a subgroup.
Well, our CEO Duncan Boak, who set the charity up, actually had a head injury the same year as you, didn't he?
That's true, yeah.
Coming up to your 20th anniversary, aren't you?
We are.
And it was because of the lack of support that Duncan set the charity up, really, but that's another story we'll come back to. So, Ed, could you just tell us a little bit more about the impact that this smell and taste changes have had on your quality of life?
Yeah, so I mean, very much in the sort of immediate aftermath, it was traumatic, and it was a huge loss. Funnily enough, I studied psychology at university, and did a module as part of my course on smell and taste. So I had a little bit of an understanding from that, and we had covered anosmia. So at that point, it was not as widely known as it is now, thanks to the COVID pandemic. But I knew what it was, and I knew that it was associated with depression. I knew that it was quite a serious thing. Whereas a lot of people do sort of underestimate how significant anosmia is. And I remember thinking when I studied it, how strange it would be, and trying to imagine what that would be like. But yeah, so I kind of was prepared to take it seriously, and prepared to you know, sort of grieve for what I'd lost, I suppose. But it is difficult because, you know, people don't fully appreciate that, and it can be tricky sometimes addressing them and talking to them and getting them to take it seriously. And sometimes you got to kind of pick your battles in terms of who you want to, you know, sort of make that point to, and who you want to just laugh it off and let it slide. And it depends what sort of mood you're in as well. And I mean, one of the things that I did to help and to kind of cope with it was to you know, sort of throw myself into understanding it more and trying to sort of, you know, rationalize it, I suppose, in some ways, and, you know, sort of understand it intellectually, so to help me to deal with it emotionally. And at the time, the only real source of information, or the best source of information, was a Yahoo Groups mailing list of you know, various people who had, you know, had anosmia of all different types and so on. Yeah, there was no fifth sense, and therefore there was very little coordinated advice or expertise available. And very typically people would struggle to get any sort of support or sympathy from the medical profession. That, you know, GPs didn't really understand it, or weren't particularly sympathetic or helpful, and there just wasn't any obvious kind of path or support, treatment, etc. from there.
And you've talked to me before about how that impacted on things like relationships. You touched on enjoyment of food.
Yeah, I mean, food is probably that's my normal kind of go-to to sort of make the point to people, I suppose, because it is, you know, the most obvious, the biggest kind of impact. You know, 90% of what you think of as taste is actually smell. But yeah, in so many ways, you know, the places have a smell and seasons have a smell. That's something I've been particularly, you know, conscious of over summer turning into autumn, etc. It doesn't ever feel quite the same when you can't get that sort of full sensory experience from it. You know, Christmas, so many wonderful smells at Christmas time that, you know, I don't get to appreciate. So yeah, and you know, sort of places and people and all sorts of things have a smell component that, again, you just don't necessarily realize and appreciate at the time. But when you lose that, everything is, you know, everything becomes a lot flatter and a lot duller, and, you know, it's like the world suddenly is in black and white. You know, all the color is drained out of it.
Yeah, thank you. And we talk a lot about health, safety and well-being, and I know that Lucia and Lisha will talk about the impact on people's mental health as well. But just one of the things that we always highlight is messaging around smell safety and taste safety as well. So making sure that people are aware of the things that they can do to mitigate any risks. I think you yourself, you haven't had any near misses at all, Ed, from what you've said, but I mean, Duncan's story.
I know that people have. You know, I don't have gas in my house.
Yeah.
And, you know, probably a smart decision not to. You know, I know that my smoke alarm batteries are all up to date. I changed those recently, so, you know, important to stay on top of that.
Okay, and we will put some links in the chat later about all of that, but it's something that we work very hard on to make sure people are aware of that, and work in partnership with Cadent Gas on. So what we'll do now then is I'll hand over to our first expert speaker, Dr. Lucia. Don't forget you can drop questions for the speakers, for both speakers, into the chat. So, and thank you, Lucia.
Okay. So can I just check you can see my slides? And great. So thank you for the introduction and the invitation to speak. I met Duncan a few years ago when he first set the charity, and I'm really impressed with what he's done with it. So it's such a pleasure to be able to speak to you. I'm going to talk a little bit about traumatic brain injury, or TBI, in general, and focusing specifically on how that links potentially mechanistically and clinically with smell and taste changes. So smell changes are, or loss of smell, is known as anosmia. clinically, and taste changes or loss of taste is known as ageusia, which are sort of nice words but don't really mean very much. So why am I interested in TBI? It's defined as any kind of injury to the brain caused by an external force. So that doesn't include things like strokes or infections or autoimmune conditions. It's where something has hit your head or you have hit your head against something else. And it's incredibly common. So there's over 400 head injuries admitted to hospital every day. So admitted to A&E, doesn't always get admitted into hospital, but show up in A&E. And if you compare that to the number of heart attacks, it's almost double. So it's really, really common. And obviously most of them are relatively mild, but quite a lot of them are not. In this country, almost half of these are due to falls. And I'm always quite surprised at how much you can injure yourself and how badly you can injure yourself falling from head height. And I think Ed's story kind of, is testimony to that. But we see people sort of fall just in their garden or anything. And it doesn't have to be that there's alcohol involved, because obviously, alcohol can sometimes sort of dull your reflexes a little bit, but it doesn't even have to be that. And I think with an aging population, we're seeing that more and more. About 15% are due to assault and about 15% due to traffic accidents. In this country, fortunately, we don't see that many penetrating injuries because we don't really have guns. Because often the penetrating injuries are, shall we say, unsurvivable, usually. So just thinking about how the brain can become damaged in a head injury, in a TBI, the most sort of obvious and one that Ed describes is where you can get a focal lesion. So there is a specific part of the brain that is damaged. And what I'm showing you here is a CT scan. So CTs show up as the skull is white, and what you see can you see my pointer actually? Yeah, you can. Okay, and the brain is a kind of grayish, fairly homogeneous, and that's normal. You should be seeing no other bits of white. And so if you do, that's abnormal. And in the context of a TBI, that's usually fresh blood. So you can see on this person here, on their, this would be the left side on a scan, their left anatomical side, that is fresh blood mixed in with some CSF, which is the fluid that bathes the brain. And you can see that the blood is squashing the brain. So actually, you should see this dark bit is your ventricle where the cerebral spinal fluid is. There should be a sort of matching one here, but that's got kind of compressed and squashed by the volume of blood here. And that's sort of what Ed was talking about, how, if he hadn't had an operation to get rid of the blood that accumulated in his brain, the brain would have been squashed, and that would have, been fatal. And that's kind of what we call a focal lesion. Another example of a focal lesion you can sort of also appreciate on this scan is, so this grey bit is the brain, but in the grey bit you can see some white that's not the sort of blood that's outside it, and that's known as a contusion, which is a fancy medical word for bruise. And essentially that's when the brain itself, as well as being damaged on the first surface and leading to bleeding around it, itself has got damaged. And that will eventually lead to scarring. So these are focal lesions. But actually, a lot of brain injury isn't appreciated on a CT scan, and you often need an MRI to pick up the rest. And that's because the hallmark injury of traumatic brain injury, as shown by lots of animal and human pathological studies, as an autopsy study, is what we call diffuse axonal injury. So that's where all the white matter, which is actually the bulk of your brain. So you've got, this is actually a pig brain, as an experimental demonstration. So when you look at the brain, you've got the sort of lovely gyri, and that's grey matters. That's all your cell bodies. And then all the white bits in the middle, these are all the connecting tracks. They're like the motorways of a country. And, you can bring a country to a standstill by I don't know, by intercepting its motorways and train lines, as we get daily demonstrations of this if you live in London and, the tube's not working or whatever. So it's actually these connections as a result of forces that are acting on the brain itself that leads to tearing of the white matter. And you can see this in a close-up autopsy specimen. This white matter, instead of being nice and white, has actually got these bleeds in it. And that's demonstrating that those axons have got torn. And it's quite hard to see this on a CT. You normally need an MRI to pick this up. But this kind of injury is also very important because it means that A, your brain has been subjected to quite high forces, but B, it's disrupting connections between brain regions, so that essentially you're not just harming or causing damage to one particular area, but you're causing damage to all the other areas that it might be linked to. And that will become relevant later on in my talk. So, I mean, I've got to admit that when I first started in TBI, I was not as aware of this as I am now. And we didn't routinely ask about this in our head injury clinic until about 10 years ago. But now it's one of the questions that we specifically ask, because people won't volunteer it because sometimes they don't even make the connection that it's related, but actually it can be very common. And the association sort of scales with severity. So if you have a relatively mild injury, so say no loss of consciousness, sort of walking wounded kind of thing, it's about 10%, so 1 in 10 people, right up to the kind of injury that Ed has described. And so 4 in 10, 40% of people, in fact, just over 40% of people who with Ed's type of injury will also have loss of smell and taste, which is actually very high, given the fact that people don't sort of recognize it very much. And the other kind of risk factor for it, or the other association with it, and it may be a bidirectional association, i.e. having the loss of smell and taste leads to the other medical problems, or vice versa, it's not known. But having other medical issues is also more common in people who have loss of taste and smell after a head injury. So how might having a head injury or a TBI lead to these smell and taste changes? So there's kind of 4 mechanisms that are posited. The first one is, if you think about the nose, you have these nerves that go into your nose endings, and then they kind of travel up into the cribriform plate, which is a bit, if you kind of just think just sort of behind your eyes, the top here, at the top of your nose, and then those nerves go up into a part of the brain known as the orbital frontal cortex, and that's the kind of cortex that sort of sits behind your forehead. So injury can happen at any point, to any point along that tract. So the first thing that can happen is the nose nerves, the olfactory nerves themselves, might experience shearing and tear, and therefore not function. The second one is to do with obstruction of airflow through the nose. So actually I had a patient today who had this as their cause of anosmia or loss of smell, which is that as a result of having broken their nose during the injury, air going through the nose, which carries, if you like, all the chemicals that you're detecting and experiencing as smell, that's all going up into your nose. But if the air blockage is stopped by a deviated septum or something like that, you can have a reduction in smell as a result of that. And then in C, you can have damage to the actual brain underneath. So from what I described before, the contusions. And then you can also have this phenomenon called hemosiderin deposition, which is where you've had a bit of blood around the brain. So maybe the actual brain itself is okay and it's not been injured, but because of the sort of superficial damage to the brain surface, and there's been blood, and then when that blood gets absorbed, it leaves almost like a sort of film of old blood, or which is very high in iron, and that can disrupt the way the brain functions. And what's very interesting is if you look at a whole series of patients, such as we have. So this is a series of over 100 patients who have come through our research studies and who have had MRIs. And what I've done here is, not me personally, one of my colleagues has, but what I'm showing here is a heat map of the contusions, of the bruising and the focal damage that you get after an injury in this series of over 100 patients. And so the more red there is, the higher the number. So if it's bright red, we've got 15 people who've got lesions in that area, and if the sort of blue is where very few people have had lesions. And what you can see is that the lesions in the brain are concentrated around the anterior temporal lobes, and which are sort of these bits here on the side, they sit just behind your ears, and the orbital frontal area, which is that kind of lower frontal bit just behind your eyebrows, really. There are sort of various anatomical reasons for this, but that has real consequences for loss of taste and smell, because the orbital frontal lobes is where your olfactory nerves, where your smell nerves go up into. So I guess the thing is, what about the other consequences of TBI, and how does smell and taste interact with that. So those of you on the line who work with TBI or are survivors of TBI will know that hereditary doesn't just affect your smell and taste, it affects a whole heap of other things. And here I've just kind of highlighted a few that we see very commonly in our clinic. So people often talk about headaches, people often talk a lot about cognitive issues, particularly around kind of slowing or fatigue. So very little exertion will make them feel very tired. Like a sort of bone tiredness, not just I'm a bit sleepy, but just kind of like I can't get going sort of tiredness. Concentration, attention is a big symptom that people often talk about. And then, you know, really kind of there's a lot of psychiatric morbidity after TBI. So 30 to 70% of people will receive a psychiatric diagnosis, typically depression or anxiety or one of the anxiety disorders, within a year of their head injury, which is a huge number. And I would say it's one of the most common things we're dealing with in our clinic. And it is very, you know, important because actually having a psychiatric diagnosis and having, you know, feelings of depression or feelings of anxiety, they really impact on recovery for two reasons. One, they can really impact on how well you can engage with rehab when it's available. And then the other thing is it can really influence your personal relationships, you know, at work, in your personal life. And those, you know, personal relationships and what you kind of rely on when you're recovering from your head injury. So it's a real, you know, mishmash and a real constellation of symptoms. So how does kind of, you know, how does TBI fit into that, and how does loss of smell and taste fit into that? Well, the first thing to think is sort of why do we need to smell? And Ed talked about this a little bit, but if anyone's interested, I can send I mean, it's a scientific review, so it's not lay language, but I think it's very clearly written and very interesting. But the idea of smell or olfaction having multiple purposes, and the first purpose is ingestion. So smell is there because it helps us want to eat. So it's not just what am I eating? Is it nice, sweet? Is it not nice and therefore probably poisonous, i.e. bitter? It's also, it drives appetite. If you think about the times where, you know, you just need to smell a bacon sandwich to start feeling your tummy gurgling, that kind of thing, it's all very linked. So it drives your urge to eat, or it's very important in your urge to eat, which is why weight loss, but also weight gain, because, you know, again, the kind of emotional aspect of eating and that drive to eat, because it's so dependent on smell, if you lose that, people can sometimes lose their ability to regulate that appetite as much as it can completely make them lose their appetite. So that's very important. The other aspect that's very important is around kind of how we perceive the world. And a really big part of that is memory. And as Ed was alluding to, you know, the smell of Christmas, the smell of, and actually, I haven't read Proust because he's entirely unpenetrable, but I am told there is a beautiful passage, and I've read that passage, which is very nicely written, where he talks about the smell of madeleines. And every time he smells madeleines, it reminds him of his grandmother, because that's one of his earliest childhood memories. And he just writes beautifully for about a page and a half about how the smell of madeleines makes him think of his grandmother, and how that brings up lovely warm memories and how nostalgic that is. And that is actually a function of smell. You know, it's about how do you use smell to drive all the other things, you know, things that make us human, things that make us appreciate, like how it drives that and fits into that. So memory is a big part of it. And then the final thing is sort of social communication. And here I put, you know, a lovely picture of a couple in love. And that's because intimacy, so physical intimacy and how you feel about your partner. So I think it's a very little talked about aspect of smell. You know, if you think about how we, you know, try our best to cover up body odor, that's for a reason. It's about sort of our lives as social animals and how we interact with each other through smell. And it's very powerful because it's non-verbal. And, you know, I'm sure you've all heard of, like, you know, 90% of communication is non-verbal. I mean, it really is. And a lot of that is visual, but a great deal of that is smell. Smell is also important because in the animal world, certainly, and actually also in human studies, pheromones, so these things that don't necessarily have a obvious smell, but which are a part of what we use olfaction for. And actually there's not very much research about whether that aspect of olfaction is impacted as much as our sort of conscious perception of olfaction. Or not that I'm aware of. So, you know, all these things around emotionality and social communication are really important functions of olfaction, as it were. And Ed alluded to this again, but something that I've found quite important, I think sort of quite shocking really, is that if you have TBI with smell loss, 6 in 10 of our patients will have depression. As compared to those without smell loss, it's only 40%. So, you know, 2 extra people per 10 who have smell loss will have depression. And that's quite important, I think, because depression is such a important factor in how people are able to interact and recover after their injury and how they're able to engage with rehabilitation, all that kind of thing. I'm starting to really sort of see smell loss as a marker, a biomarker for people that I need to just keep an eye on a bit more and ask a lot more deeply about their mood and really do a sort of quite positively do a depression screen on them rather than wait for them to volunteer that. And why might that be? So this is actually, I searched ages for a nice anatomical thing that wasn't too complicated, but also I think this is really good. So just bear with me as I break it down, because it looks a bit like an alien, and I think that is because bits of the brain are quite alien looking. So focus first of all on this very small inset bit here, because that's going to help you orientate within the brain. So what this big blow up bit here is the limbic circuit, which is the circuit that is, quote unquote, responsible for emotion or emotional function and regulation. And it essentially composes of a lot of central structures in the brain, and it arches over. It sort of starts at the amygdala, which you know, probably sits just behind your ear holes, and then it kind of, these structures arch into the middle of your brain and then forward into just behind your eyes. But what I really want to sort of draw your attention to is what is considered absolutely integral to the limbic system. Yes, you've got your amygdala, which is kind of, oh, I've lost my mouse, which is kind of this sort of berry-looking thing in the structure. And then you've got your hippocampi, which is your memory, sort of, it's really important for laying down memory. It's the bit that's shrunken in Alzheimer's, so really important. You've got the fornices, which are essentially white matter structures that link all these bits up. Goes down, and then look, you've got your olfactory bulbs. So in the limbic circuit, the olfactory bulbs, i.e. your smell organs, are absolutely key. And then what it's not showing so well in this picture, presumably because you have to strip it all away, sorry, is the cortices. So around these areas, you've got very key brain regions known as the insula, the anterior cingulate, and the orbital frontal cortices. And all of these areas are all considered part of the limbic circuit. So areas of the brain that are important for emotion, important for sort of aspects of personality, but also are part of the olfaction system. So there's so much overlap, it's perhaps not surprising that olfaction is so important in everyday function. So just to round up, as I've mentioned, the loss of smell and taste is very common after head injury. It's caused by injury at any point in the olfactory pathway, and its consequences probably reflect or do reflect the wide range of functions for which smell and olfaction is important.
Thank you so much, Lucia. That was so clear. And just to say to everyone, a recording of this will be available, so we'll be able to slow down and look at the slides that Lucia's talked through and really absorb all the information that she's given us. So what I'd like to do now straight away is just hand over to Miss Lisha McClelland, and then we'll have Q&A after Lisha's spoken. Thanks, Lisha.
Can you see the screen okay, Mags?
Yes.
Lovely. Okay, thank you for the introduction. So we're going to do whistle.
I'm really sorry, Lisha. I'm really sorry. I accidentally muted you instead of myself.
Okay, not a problem.
Again, sorry, my fault.
That's okay. So we're going to do a whistle-stop tour through diagnosis, examination, investigation, management, and self-help. So we've already heard a little bit about head injuries, but where does it sit in the kind of general smell and taste loss? Well, it's about a sixth of the patients that we will see in a smell and taste clinic. So really quite an important cause for us to think about. From my point of view, probably the key thing is talking to patients. And as Ed has alluded, sometimes medical professionals aren't very good at listening and hearing. So I try to take a lot of time in clinic to really understand not just kind of what the current issues are, but also how it's happened. So if we think about the mechanism of injury, we need to know how it happened, whether it was the front of the face impact or the back of the head impact, because this will let us know whether there's going to be any injury to the front of the nose, which Lucia alluded to, or whether it's more going to be a brain and nerve injury. So I want to know about the nature of it and what exactly is the problem. Is this purely olfaction? And in terms of smell, is it purely that I can't smell anything, or that I have a reduced sense of smell? Or is it that I've got distorted smells, that things smell different from how they used to, or that I'm getting extra smells that nobody else can smell? Is it a taste problem? And when we think about taste, we want to think about primary taste, so sweet, sour, salt, bitter, umami, and the trigeminal nerve, which does hot and spicy in the mouth. Or is it more a flavour problem? So about 70 or 80% of flavour comes from our sense of smell, which Ed told you about. I want to know if there are any specific nasal symptoms. So not just after the injury, but were there any problems beforehand? Is there an underlying problem that's been unmasked or made worse by the problem? So things like hay fever or pet allergies or previous injuries to the nose are really important. But also, are there any new nasal symptoms? Is there anything to suggest that there might be any ongoing issues? So discharge or leakage from around the nose area. If it's a taste problem, we might concentrate more on the mouth. Are there any specific changes, any difference in your biting or your chewing, dental position, anything that could suggest an injury to the mouth area? I'm going to skip over kind of some of the more systemic symptoms and medical problems just for time and expediency. So we're going to move on to the nose. So we want to have a really good examination, not just of the outside of the nose to see if there are any obvious changes, but to the inside of the nose. So in this picture, this is the inside of the nose, and this is the right side of the nose. So we've got the septum, which is the middle. We've got the inferior turbinate, we've got the middle turbinate, and we can see kind of a dark pathway to where air flows. On this side, when we look up, oops, sorry, I've moved the slides too quickly. On this side, we can see kind of a blobby, almost like a green grape appearance, and that's polyps inside the nose. So sometimes when we look out inside the nose, we find unexpected things like polyps, where people didn't know that there was a significant problem inside the nose before an injury, but it becomes unmasked, it becomes more obvious when there's been an injury to the nose. In terms of investigations, sometimes we need to investigate, sometimes we don't need to do a lot. And it really depends on kind of the nature and the severity of the head injury, what's already been done, if there are any other kind of ongoing issues that might suggest another kind of coexisting or ongoing problem. So sometimes we might need to do some blood tests. So particularly if there's been an injury to some of the glands inside the head that might produce hormones that might suggest that there's a kind of a coexisting medical problem. Or if the diet's been very altered, maybe you lost lots of weight, we might want to check that there's not mineral and vitamin deficiencies that might also be really important. Sometimes we might need to do some scans to see if there's kind of any ongoing or missed injuries to the brain or the sinuses, just so that we know exactly what's going on. The other thing that we'll often want to do is a smell test, and there are lots of different smell tests out there. I've put on the sniffing sticks, which is one of the common ones we use, and I quite like it because if you look at this chart, it breaks it up into 3 sections. So there's this threshold section. How strong does something have to be for you to be able to smell it? A discrimination. Can you tell the difference between 2 smells? So this might be more towards the trigeminal. Can you tell if there's an odor present versus nothing present? And then identification. Can you tell specific smells? And this is really important because Injuries to the sense of smell, sometimes they affect everything, but sometimes they just affect very specific parts of the smell. And knowing what you can smell and what you can't smell not only helps you understand your problem, but it also helps you tailor maybe the treatments towards specific areas that you need to work on. In terms of management, really depends kind of where we see you in the pathway, what we're going to recommend. So in the acute setting, there's a little bit of evidence for zinc supplements. And there might be some evidence for steroids in some people. Now, I'm going to qualify that. We'd always have to work with other medical professionals whether steroids are appropriate for a patient. And sometimes in a head injury, it's not. And sometimes for other medical reasons, it's not. Sometimes we can use topical steroids where we can't use oral steroids. So sometimes we might get you to do some steroid drops or steroid washes to reduce inflammation and swelling inside the lining of the nose to help those smells get up to the smell receptor tissue that Lucia has beautifully demonstrated. We want to treat any associated conditions. So particularly if there's underlying hay fever or polyps, it's really important to treat those so that we know whether this is a conductor problem, a problem with smells going up the smell receptor tissue, or whether this is more a nerve problem with smells going from the nose up to the brain area. And it may be appropriate to treat surgical damage. Now, sometimes that's done acutely. So if you've got a fractured nose, sometimes we'll manipulate the bones within the first few weeks. Sometimes within a head injury, the injury is too severe and there are other problems that need sorting out much earlier or in advance of what we need to do with the nose, and they have to take priority. So we have to deal with the nose problem, the structural problems, at a later date, which can be a little bit more challenging. And other things that might be used, and it's a balance of risk and benefit, and sometimes much later on in treatment, are things like sodium citrate. So there's a little bit of evidence that if you've got a reduced sense of smell, that sodium citrate washes can give a little bit of a boost before you want to eat or drink, just for a short period of time, maybe 15-20 minutes. Some vitamin supplements might be appropriate, and things like omega-3, alpha-lipoic acid. And very occasionally we think about theophylline, which is a medicine that's been used for a long time in respiratory disease as an oral medicine. But sometimes we can get hold of intranasal theophylline, and there's some experimental research to suggest intranasal theophylline might be helpful at bringing smell back. Other things we need to think about are safety. So we've talked a little bit about kind of smoke detectors, but also if you've got gas appliances, gas detectors in the house. Thinking not only about home, but work, other environments that you might need to work in, making things as safe as possible. And diet, not only making sure that you check your sell-by dates and labels on food to make sure that you're safe, but also the effect it has on what you're eating and drinking. We want your body to be as healthy as possible so that it can repair and regenerate. So making sure that you've got a healthy, balanced diet with all the vitamins and minerals that you need to repair your body. Self-help is really important. So whilst I would love to repair nerves, I can't. And we know that the body is the best at repairing itself. Sometimes that's really quick if there's just been a bit of swelling and bruising at the front of the nose. Sometimes it's a little bit longer if there's been bruising to the nerves. Sometimes it can take an awful lot longer if there's been more serious damage to nerves. And sometimes, unfortunately, it doesn't recover fully. But there are things that you can do to try and support recovery. And smell training is one of them. I'm sure you're an interested and enthusiastic audience. I'm sure you've done your homework and you know about smell training. But for those that don't, it's a type of therapy for your sense of smell where you try and expose yourself repeatedly to the same types of smells. So if we look at this graph, this shows people who don't do any smell training, and this was looking at people with smell loss for all causes, not just traumatic brain injury. So without smell training, we're here. With kind of traditional smell training, you get an improvement, and with modified smell training, you get even more improvement. So the traditional smell training was just rose, clove, lemon, and eucalyptus, and we did that for kind of 3 months period. With modified smell training, we know that it's an ongoing process, and that smell training helps you get better at smelling individual smells. So what we want to do is, over a period of time, to build that up so that you smell train on different smells. So you might do rose, clove, lemon, and eucalyptus for the first 3 months, and then swap them out for the next group, and 3 months later swap them out for the next group. You might find that those are all really, really easy, and after the first month, you swap them out to a new group. So it's very, very self-directed. But what I like to encourage patients is not just to bottom-up train, not just to expose your nose to smells, but to think about it and expose your brain. So write the word rose down, put pictures of a rose, try and think about what you're doing so that you're linking your nose with your brain and trying to put that information all back together again. So what's the prognosis? Well, I know that a lot of you have been given really, really dire prognosis and have been kind of fobbed off by the medical profession. And all I can say is I'm really, really sorry. And that I try to keep a much more positive outlook in clinic. There is hope. There is hope of improvement over a very long period of time. So maybe a third of patients will recover in 5 years, and maybe up to half of patients will recover in 10 years. So it's a long, slow process, but it can happen. And even if it doesn't happen fully, even just small improvements in your sense of smell can really improve quality of life. And I would say with smell training, not just concentrating on olfaction, but concentrating on trigeminal sense. So some people get really good at using the trigeminal nerve, and in the nose, that does kind of chemical sense, being able to smell or sense rather than smell things like bleach and petrol, those strong chemicals, which are really good early warnings for when you're around kind of maybe harmful chemicals and odors. So work with it, try and think about what you can smell, what you can perceive, even if you can't identify specific odors. For the future, I think we need much more research on how to repair nerves and regenerate nerves. And I'm really hopeful that within our lifetime that might happen. So I'm going to hand over to Mags, because I know she's going to kind of chair the next session on questions.
Thank you so much, Lisha. That's great. Both talks, and we've had lots of comments in the chat just saying how beneficial both talks have been. So thank you both for that. I'd like to kick off some questions just before we hand over to the questions that have come up in the chat, but just to highlight a few things really. So just firstly, really to Lisha. So given how few smell and taste clinics there are in the UK, and just how long the waiting lists are to see an ENT consultant who specialises in smell and taste disorders, what would you like to highlight to any GPs who might be watching this event or watching the recording if they're considering a referral to you? Is there anything that they can do or try ahead of the patient's first consultation with you?
Certainly. So in the acute setting, ruling out any problems at the front of the nose, so treating hay fever and allergies, GP will be well used to treating hay fever, allergies, chronic rhinosinusitis, all the coexisting medical problems. Signposting patients to your website, Fifth Sense. You've got a beautiful website, lots of really useful information, lots of it kind of support there, so that patients aren't on their own right from the get-go, that they've got sources of information. You know, there's in the acute setting, they can try zinc. You can try zinc. It's freely available from Holland & Barrett, Boots, and it's relatively low risk. So trying that for a period of time, seeing if it makes a difference isn't a problem. Even some of the stronger sterile washes, GPs have access to those and can try as well to take down any acute swelling inside the nose if there's been an injury at the front. So I think most of what I said, you can give a go yourself. You know, patient who come to see me 12, 18 months down the line, I might be more kind of tweaking and changing smell training, seeing where they are in the spectrum, maybe addressing more things like the phantom smells or parosmias or kind of ongoing issues that they're having.
Thank you. And I'm very conscious we tend to have spoken mostly about smell loss when there's also phantosmia and parosmia and all sorts of other things that can happen as well, and taste changes. So and also, what would you highlight to patients? I mean, you've talked about smell training, modified smell training. Is it useful for patients to do this in advance and maybe keep a smell diary?
Yeah. I mean, it's an ongoing process that might take months to years. It's not going to be a quick, easy fix. So, I appreciate immediately after a head injury, you probably have better and bigger things to worry about. And it might take a long time for, the cognitive side of things, your kind of concentration, your ability to remember and to think about things to come back. But when you've got the time and energy for it, then that's the time to start thinking about it.
Mm-hmm. And that's one of the things that we're conscious of, is trying to provide information so it's easy for people to access at the point that they need that information and may not want to be searching around all over for information. Okay, thank you. So we'll go straight into the Q&A. I'm going to try and prioritise things for Lucia first, because you have to leave very soon, don't you, Lucia? You've already answered some of the questions in the chat, but I'll just draw them out really, if that's okay. So is it helpful for us to know which part of our brain has been damaged? And you've already put an answer in there. If you wouldn't mind just talking a bit more about that.
Yeah,
Please,
so
Lucia.
yes and no. I find it diagnostically, as a scientist and as a doctor, to know what's going on in the brains of my patients, given that I'm a neurologist. So I always try and get a scan. We know that some areas of the brain do map onto certain functions. We've both talked a lot about the orbital frontal cortex. However, you don't have we've moved on from phrenology. We don't think that there is a part of the brain for, recognizing your grandma. There's not a part of the brain for knowing that conkers are not edible. It's your brain works as individual areas, but also as a kind of network. So just because there aren't individual areas damaged, it doesn't say that you don't have X or Y, Z problem. And also function is as a result of lots of different cognitive processes. So it really depends on what the answer is that what the question is that you're trying to answer.
Thank you. Someone who says they had a CT scan but not an MRI scan because they're claustrophobic. Can you say what information is missing and not available to me because of that? And you've answered that to say that a CT scan will show us big areas of damage and it may not pick up the smaller areas.
Yeah. So, you won't see white matter damage, or you may not see white matter damage. We've got a few patients who've had a normal CT scan, have always had a normal CT scan, and they have an MRI and they show areas suggestive of external injury.
Yeah. So if an MRI was achievable in that case, would it be advisable?
Again, it really depends. There's no point forcing yourself to do a scan unless it's going to answer the question you want to answer. So it really depends on the question, and that's worth discussing with your neurologist or your GP.
Yeah. Okay. So does smell and taste often return following a CBI? This is from a case manager for a 14-year-old who had a TBI in February and has lost the senses.
So I think we've got evidence that there can be return, maybe not fully, but it can take months to years. And patients as a teenager is not easy. And doing kind of persistent things like smell training is not easy, but encouraging it as much as possible. If we look at patients with anosmia, then there's probably a much slower and less full recovery than patients with hyposmia, but that's not universally so. So I think seeing a specialist is a good idea to know kind of where you are in the spectrum. You may know yourself just from what you can smell and what you can't smell, but getting kind of a more formal kind of diagnosis and making sure that there's nothing easily reversible or treatable is important.
Okay, thank you. And a couple of questions around kind of delays in getting investigated, really. So one person says, can I still be referred to a smell and taste clinic from my GP? I'm 2 years post TBI and I'm based in the UK. And someone else who had an accident when they were abroad, who I can't find the comment now, 8 months ago, and everything else seems to be okay, except for the loss of smell. And they've had CT scans abroad, but not an MRI.
So I have seen patients 5, 10, 20 years after the brain injury, and I hope the visit to clinic's worthwhile at any stage. A lot of the time, it's just reassurance that they're doing the right things or that nothing's changed in terms of medical advances. I think I wouldn't get too fixated on whether you've had CT or MRI imaging, because with the best will in the world, it doesn't change the management often. You know, if you've had a brain injury, you know you've had a brain injury. It doesn't really make a difference, kind of the exact picture or extent of it in terms of what you do afterwards. So I wouldn't get too focused on it. I think the main thing is to start your recovery.
Okay, thank you. Someone who's saying, if there has been a complete shearing of nerves, I have thought it was impossible to smell again. Is that not the case?
I don't know
Yeah,
whether
I'm not
Lucia wants
sure.
to answer that one or me.
I don't know how you would even assess for that, because yeah, I mean, it's not something that we can really go into assessing. I don't think MRIs show it very well, and you can't do an electrophysiological test like you can do with sort of visual and hearing. So I think you kind of go by, you know, likelihood based on your history of your accident. And yeah, I think it's tricky because COVID sort of insinuated that you could get recovery of olfactory nerves, but they are at that border between central nervous system and peripheral nervous system. And we do know, you know, central nervous system nerves don't really grow back, but peripheral nervous system do. But then you can get compensation and, you know, rewiring. So yeah, Alicia, you may know a bit more about this.
Well, I would just assume that there's going to be some recovery, even if it's not total, because you've nothing really to lose by trying smell training and trying some of the things that we're talking about. You know, what's the worst that can happen? You get a bit, you know, disillusioned and disappointed, but is that any worse than where you are at the minute? I don't know. I think it's worth giving it a go. And as Ed and Duncan would say, you know, even decade after their injury, even 20 years after their injury, they're still noticing new things. They're still kind of developing new ways of kind of appreciating, even if it's not returned fully.
Yeah, so I've definitely had some recovery. At first there was nothing for many, probably for years afterwards. And I think the first thing, one of the things that I get strongest now is the smell of fish. And it's not exactly what it was before, but if there's a fish shop around the corner, I can smell it. And recently I feel like it's recovered, you know, a little bit more as well. It's still nothing like a proper sense of smell. It's still, you know, I'd still say I'm anosmic rather than, you know, partial. But yeah, there's definitely hope. There's definitely the potential for it to recover over time. The way I think of
Thanks.
it.
Can I just interrupt you for a second, Ed, just to
Sure.
say Lucia needs to go now. So I
Yeah.
just really want to thank Lucia on everyone's
Thanks,
behalf.
Lucia.
We've had some lovely
Pleasure.
comments, Lucia.
Sorry for
Thank you
having to
so
run off.
much for your time.
My nanny
Totally
finishes now,
appreciate it.
so-
Thank you. Bye. Bye
Take
now.
care.
Sorry, Ed.
No, I was going to say that the way I think of it in terms of this recovery is just like the professionals were saying, that it's as I understand it, we can't really scan to see if the nerves are there, if they're recovering. Clearly there must be something still connected, but it's damaged at some point. So the analogy that I think of it as is as if I've got a video camera connected to a TV screen, and at first it looks like it's just complete static because the wire's been damaged that's connecting it, but there's still some signal getting through, and either over time that wire has repaired so that the signal can get through, or the TV's got some software in it, i.e. my brain, which is now able to deal with the degraded signal from the video camera better to create some sort of meaningful image on the screen that wasn't there before. That's how I see it.
That's really helpful. Thank you, Ed. Brilliant. One of the questions in there is, I'd like to ask why there seems to be so little understanding of the issue until very recently. I've heard this was due to a lack of research and training, but is it because losing your sense of smell wasn't seen as too important? Lucia did answer that in the chat, saying I think it's a wider issue of TBI being a hidden disability. People can do physically well, and there is that feeling of maybe you're just lucky to be alive and you're fine because you look fine. But this is one of the things that Fifth Sense is obviously here to do, and we're trying to advocate. This is what these patients and professionals events are about, to draw out the impact that it has and what people can do, whether they're a professional or a patient, to try and help that. So it's all about raising the profile. Yeah, so thank you for that point, really.
Someone asked about whether smell training is actually a good thing or whether it can have a negative impact, because it reminds you that you can't smell, right? And there's definitely an element to that. And that reminds me of my relationship with food. Sometimes I will have something really spicy, or something with some ginger or some mint, or something really sharp and sour, or sweet, to kind of give me some stimulus, and I can sort of try and compensate for that. Other times I just don't want to think about that. I just want to have something really bland and plain, and just where I can just eat it quickly, easily, and forget about it. It very much sort of swings both ways. It varies quite a lot how you sort of feel about that, and how you want to whether you want to kind of lean into it or not.
Can I just add some extra things to that, Ed? Thank you. So I'd often encourage standard smell training, kind of formal smell training at the start, but maybe kind of 18 months, 2 years down the line, if there's really nothing coming through and people are fed up with smell training, then what I try to do is, or even throughout that, is try to get the smell memories working. Some people get really good at accessing their smell memories and will get little flashes when they do everyday things. So rather than ignoring the smells around you during the day, just when you're washing your hair, think of the florals. When you're brushing your teeth, think of the minties. When you're drinking your coffee, think of that kind of burnt, kind of roasted aroma. So to try and put it more into the everyday, rather than something that you specifically sit down to do that might be frustrating or depressing, and just to try and keep your brain active, because there's a bit of information that suggests that just accessing your smell memories helps plump up your olfactory bulb. And if we think that there might be future kind of improvement, we want your olfactory bulb working as well as possible.
Thank you. Would you recommend, if somebody is really struggling and they're finding it really depressing, to just take a break from it, come back to it at a later date if they're more amenable to doing it? Yeah,
but also if you're depressed, think about the depression itself, and sometimes depression needs kind of looking at as a separate kind of entity. Sometimes it's just talking to people, sometimes it's support, sometimes it's cognitive behavioral therapy, sometimes it's medication. So there's lots of routes to go down. It can be a cycle and it can be vicious.
Yes, thank you. I'm conscious of time, and we don't like to run over with these events because people will stop attending them if we just go on forever. So a couple of things just to finish off, really. I've noticed I can identify weird smells linked to onion, garlic scents lately. I'm hoping this sign is positive, in the right direction to some sort of recovery. You're nodding, Lisha.
Yeah, I tend to think of parosmias as a positive thing. I tend to think about smell a little bit like playing piano, that when you press a chord, you smell something, but if you've injured some of them, you might hit a bum note and smell something different. So the fact that you start to get some stimulation, even if it's not the right stimulation, I tend to think as positive. What I would say is, don't get too fixated about the kind of the bum notes, and try and put it back together with what you remember the smell to be, so that hopefully over time your brain will relearn what that smell is, even if it doesn't return quite to normal. If you're finding that the parosmias or phantosmias are really kind of annoying you, then sometimes carrying around something that you can smell that you like, so lemon or cinnamon can help. Sometimes chewing gum, menthol chewing gum, something minty, sugar-free, so you don't annoy your dentist. Or sometimes just distracting your brain and doing something different. So, listen to some music, go for a walk, do a crossword puzzle, something just to get you out of a negative loop and into a positive frame of mind.
Yeah, thank you. So there's a couple of other questions which I think what I might do is leave for now. One of them is from a speech and language therapist working in dysphasia, talking particularly around taste. Now we are going to be having an event on taste in November, so I'll talk more about that in a moment. And I wonder if that person would email in to me at information@fifthsense.org.uk, and we can pick that conversation up. And the same, Beverly, with you talking about the smell training kits. So there's lots of ideas coming out there, and we can take them separately. So what I'd like to do now is end the Q&A bit there, and just share a few notices that we'd like you to be aware of. So we will be uploading this event, a recording of this event, onto our YouTube channel. Sally and I need to spend some time adding captions and doing the transcript. We like to make sure that it's easy for people to follow and it's worth the time to do that. So that should be either later this week or sometime next week that we manage to finish that. So if you're particularly keen on that, you can email in and I'll let you know when the recording's being uploaded. We've talked quite a bit about the need for support and signposting and that kind of thing. So we have a Let's Talk Smell and Taste Acquired Anosmia support group coming up on the 23rd of October. That event, if you're interested, will be at 7 o'clock till 8:15. Our support events are later. I made a mistake when I did the marketing, so you'll find the ticket, there's an error on the ticket. It says the earlier time, which is what the patients and professionals events are. So my apologies for that. I will send a reminder email to anyone who books on. But that's a great place to get that support from other people who really know what you're dealing with, and to share hints and tips and just continue the conversation. It's very informal. Anybody who's not been, it's mostly now putting people in chat rooms to chat to each other rather than anything that we lead. And that seems to be beneficial. We always share the smell safety messaging every time though, because it's so important. If you're experiencing parosmia or any sort of taste distortions, then the right group for you would be on Wednesday, the 13th of November. We've got a parosmia support group, so that covers all smell and taste distortions, really. If you're not already a member, you can join Fifth Sense for free, and that's where you'll find out more about the events and the booking. You can also see us on Facebook and all the social media channels. And as I say, anyone can email in with questions to information@fifthsense.org.uk, and we'll try and answer your questions. So Sally will be dropping, I think she may have already dropped a little survey into the chat. So it's really helpful for us if you would complete the survey, just so we know what we did well, what we can do better, any ideas for future events as well. So we're planning our 2025 programme. So if there are things that you think would be helpful, do let us know. And also, these events are free. We think that's really important to make sure anybody can access any of our events. But if you are in a position to make a donation and you've had some value from this event or from any of our materials and resources and that kind of thing, then please consider making a donation. Any donation is gratefully received and helps us to run these kind of events. And something else I was going to say and I can't remember what it was. But I'd just like to end really by thanking everyone. I'd like to thank both speakers, expert speakers, and also our expert patient Ed. You know, the comments in the chat are testimony to just how valuable people have found this event. And it's nice to do an update on where we're at with things, isn't it? Our information that you can access through our website, our information sheets, that kind of thing. I think Sally's been dropping into the chat as we go. They're useful resources for you to share, for example, with your GP, especially the talking to your doctor sheet, which it's easy to think, oh, I know how to talk to my doctor, but it helps you to capture the kind of things to mention and the things that everyone's emphasised this evening, all the speakers have emphasised about the impact it has. It's really nice to have some backup, isn't it, when you're trying to get your point across to someone who may not have come across it yet. And I thought it was really interesting that Lucia said that it's only in the last 10 years, really. Or was it you, Lisha, that said only in the last 10 years this has been taken seriously? It was Lucia, wasn't it, when she was talking about TBI? Yeah,
It was.
so that's interesting, yeah. So I'd like to thank you all for attending and close the event.